Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Randomized Placebo-Controlled Double-Blind Phase 2 Study of Axitinib plus Docetaxel versus Docetaxel plus Placebo in Patients with Metastatic Breast Cancer by Hope Rugo. My name is John Mackey, and I'm a Professor of Medicine at the University of Alberta in Edmonton, Canada. My oncologic specialty is medical oncology. To begin, I'd like to acknowledge that my cancer center participated in the study under discussion, and as a local sub-investigator, I recruited patients to the study. However, I am not a co-author on this trial and was not involved in data analysis nor manuscript preparation. Treatment of cancer using anti-angiogenic agents is based on several hypotheses. There is a continuously expanding network of capillaries supplying nutrients and oxygen to support tumor growth. The process of angiogenesis can be blocked therapeutically without causing excessive host toxicity, and such treatments will induce a state of tumor dormancy. The discovery of the vascular endothelial growth factor family of angiogenesis stimulators, including VEGF-A, B, C, D, and placental growth factor, spurred the development of several VEGF pathway inhibitors. These agents include antibodies to VEGF-A and its receptors, as well as a host of small molecule tyrosine kinase inhibitors that act inside the cell to target the catalytic function of VEGF receptors expressed by endothelial cells. The clinical benefits of anti-angiogenic agents have been well established in colorectal cancer and renal cell carcinoma. The role of anti-angiogenic therapy in breast cancer, however, is in particular flux, as the initial promise provided by the E2100 study of bevacizumab in combination with weekly paclitaxel has not been confirmed by subsequent bevacizumab studies in metastatic breast cancer. 3 global adjuvant bevacizumab studies have completed accrual but have not yet reported outcomes. Similarly, small molecule inhibitors of angiogenesis have shown only modest efficacy signals when combined with chemotherapy and add significantly to toxicity. With this background, we will now review the latest addition to our understanding of anti-angiogenic therapy for breast cancer. The present study evaluates the effects of a small molecule tyrosine kinase inhibitor called Axitinib. Several small molecule oral TKIs have been designed to target the intracellular catalytic functions of VEGF tyrosine kinase receptors expressed by endothelial cells. Axitinib targets VEGF receptor 2, the primary signaling receptor for VEGF-mediated angiogenesis. Axitinib also targets VEGF receptors 1 and 3, the platelet-derived growth factor receptor, and c-KIT. While there are no other studies of Axitinib in breast cancer, single-agent activity of Axitinib has been demonstrated for other solid tumors. In this edition of the Journal of Clinical Oncology, Dr. Rugo and colleagues report the final results of a randomized, placebo-controlled Phase 2 breast cancer trial comparing docetaxel with Axitinib to docetaxel and placebo as first-line treatment for metastatic breast cancer. The chemotherapy backbone of the study was docetaxel given at 80 milligrams per meter squared every 3 weeks. Women in the United States, Spain, Canada, Italy, Germany, the United Kingdom, India, and the Czech Republic were recruited between 2004 and 2006. 168 women were randomized in a 2-to-1 ratio to Axitinib 5 milligrams twice daily in the combination arm or to placebo. Their median age was 55, and all had HER2-negative, measurable metastatic breast cancer without prior chemotherapy in the metastatic setting. Clinical characteristics were well balanced, and approximately 70% of women had prior adjuvant chemotherapy. The preliminary results were first reported as an oral presentation at the American Society of Clinical Oncology meeting in 2007. This was abstract 1003. At that time, Dr. Rugo reported statistically significantly improved response rates, which were 23% on the placebo arm and 42% on the combination arm. Time to progression was also significantly prolonged by the addition of Axitinib from 6.3 months to 9.0 months. In this final report, follow-up is now mature and virtually all women experienced progressive disease. Time to progression was no longer significantly prolonged in the combination arm compared to the placebo arm, 8.1 months versus 7.1 months. However, investigator-assessed response rates remained significantly higher, 41% versus 24%, even though 20% of patients were not assessable for response. No survival data are presented. Women in the combination arm had more frequent requirements for reduction in docetaxel dose and generally higher levels of toxicity. The Axitinib combination was associated with several toxicities, including increased fatigue, diarrhea, stomatitis, hypertension, and a doubling of the rate of febrile neutropenia. This randomized phase 2 study has many strengths, including appropriate masking of treatment allocation by use of placebo, minimal loss to follow-up, and careful attention to assessment of toxicity. Weaknesses include the phase 2 nature of the study, from which definitive conclusions cannot be drawn due to sample size, the investigator-assessed nature of response, and the lack of survival data. Although the study did not meet its primary endpoint of increasing time to progression, there is evidence that Axitinib has some activity in this setting, as suggested by higher response rates and a particularly interesting pre-specified subgroup analysis. In those women who had received prior adjuvant chemotherapy, which comprised 70% of the subjects, the investigator-assessed response rate was threefold higher for the combination versus the placebo arm, 47% versus 13%, one-sided p-value 0.001. In contrast, there was no difference in response rates among women who had not received prior adjuvant chemotherapy. This observation may be relevant because similar effects, where efficacy seems higher in patients who received prior adjuvant chemotherapy, were noted in the E2100 study, the Avado trial, and Ribbon 1. However, mechanistic explanations for such an effect are lacking, and the evidence is not yet strong enough to suggest that prior adjuvant chemotherapy treatment warrants anti-angiogenic therapy on relapse. Ultimately, the decision whether to use a new agent rests on the balance of toxicity and efficacy. Axitinib, when combined with docetaxel in this fashion, has not shown sufficient efficacy to outweigh the substantial additional toxicity seen in this study. This result is not particularly surprising, as small molecule anti-angiogenic drugs have yet to achieve a sufficiently favorable risk-to-benefit ratio in advanced breast cancer. Motesinib, also an inhibitor of VEGF receptors 1, 2, 3, the PDGF receptor and c-KIT, has similarly been tested in a randomized phase 2 study. When combined with weekly paclitaxel, it numerically increased response rate and time to progression over weekly paclitaxel plus placebo but at the expense of higher toxicity rates. Sunitinib, a multi-targeted inhibitor of VEGF receptor 1, 2, and 3, platelet-derived growth factor receptor, c-KIT, FLT3, and RET, has been evaluated in randomized trials, but development in metastatic breast cancer was halted because the studies failed to meet their primary endpoints, and increased toxicity was apparent in the combination arms. Sorafenib, a small molecule TKI, has both anti-angiogenic and anti-proliferative activities. In 2 randomized phase 2 trials combining sorafenib with chemotherapy, only modest improvements in activity were seen. Further, the sorafenib and capecitabine combinations produced very high rates of grade 3 and 4 hand-foot syndrome. A phase 3 registration trial combining sorafenib and capecitabine in metastatic breast cancer is underway. To conclude, Rugo and colleagues are to be congratulated for carefully evaluating a small molecule anti-angiogenic drug in women with metastatic breast cancer. However, their results suggest that Axitinib joins the growing list of anti-angiogenic agents that have yet to demonstrate meaningful improvements in the risk-to-benefit ratio of first-line chemotherapy for metastatic breast cancer. This hurdle must first be met before we can realistically expect these drugs to budge the most critical endpoints for our patients with metastatic breast cancer, overall survival, and quality of life. This concludes the JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.